Good morning to you and welcome to NTV Medical Matters. I am Viola Kusasira here on NTV Uganda, a bright new morning, and we are so happy to have you. Today we are going to be talking about something that is common and is amongst us, but sometimes is taken lightly, and that is maternal mortality, which stands at 189 mothers dying in every 1,100 live births here in Uganda. And today we are here to find out why is this happening, but also how can it be reduced so that we have less and less figures as the years go by. So in studio, we are joined by Dr. John Paul Bagala. He is an Assistant Commissioner, Reproductive and Infant Health at the Ministry of Health in Uganda. And Doctor, thank you so much for joining us.
Thank you very much indeed, Viola. I'm very happy to be at NTV. Health matters specifically.
Medical matters.
Medical matters, and discussing an issue that is core to us. One, the division that I lead of reproductive and infant health within the Reproductive and Child Health Department, but also as the Ministry of Health. So I'm very, very happy to be with you this morning. And Happy New Year.
Happy New Year. Yeah, very, very true. Happy New Year to you. And Happy New Year to our viewers. Yeah, you reminded me of that. So let's start off with understanding what maternal mortality. When we talk about it, how can you simplify that term for all of us to understand?
So maternal mortality, in simple terms, is the death of a woman, either during pregnancy or childbirth, or after giving birth. After giving birth, we have a particular duration that we look at, 42 days, which is about 6 weeks after childbirth. But if the death of that mother is as a result of those three, the pregnancy, childbirth, all after childbirth, that's what we call maternal mortality. But it has different, there are different categories of maternal mortality. There's what we call the direct maternal mortality, which now, if a mother dies or if a woman dies, and the cause of death is the pregnancy she's carrying, it's during childbirth or the period 42 days after childbirth, but that cause is purely attributed to the pregnancy. That's a direct maternal mortality. But also we have women who tend to die, and yes, they have been pregnant, but the cause of death is in no way related to the pregnancy. And a mother can have an underlying condition, like you can be pregnant and you have a cardiovascular disease, or you have a problem with your heart, you could have a problem with your kidneys, or you could have another chronic condition. And because of those other conditions that you have, you end up losing your life as a mother. Now that's what we call an indirect maternal mortality. So as the ministry, we try as much as possible to classify whenever maternal death occurs. We have to appreciate what caused that maternal death, because it's very important for us to be able to address and ensure that we don't have another maternal death occurring as a result of a similar cause that led to the previous one.
So from your perspective, what types of mothers are at a higher risk?
So if a mother has had multiple pregnancies, and in most cases our fertility rate is now 5.2, where we expect right now every woman, at least based on our statistics from the Uganda Demographic and Health Survey, at the ministry, when we did that survey, we found out that every mother has at least 5 children. But you find that in some cases, a woman gets quite many pregnancies. For every pregnancy, of course, we term it as a low risk. But there are chances of that low risk pregnancy becoming a high-risk pregnancy. And I think, as we shall discuss further down in our conversation, we will touch a little bit of how do we ensure that we are preventing this low-risk pregnancy from becoming a high-risk pregnancy that could then turn out into causing a mortality. We've had mothers that are at the extremes of age. As a country, we still have a challenge of teenage mothers. Those are high-risk mothers. And because this teenage mother, it's not just about the pregnancy that she carries, but there are lots of complications that she can have as the mother and also the baby. So she's a high-risk mother. A mother who has a comorbidity, or what we call an underlying condition, in addition to the pregnancy, as we had stipulated that you might have hypertension. And I think down the line we might be able to discuss one of the second most cause of maternal death, which in our term we call it preeclampsia, but it's basically when the blood pressure rises in the pregnant mother. Those mothers are high-risk mothers, and the way we handle them is quite different. If a mother comes and she's carrying more than one baby, we don't handle that mother in the same sense as we would handle the mother who would come with one baby.
For a mother that is mostly healthy, at what stage do you usually see complications developing in pregnancy?
The complications can develop at any time for as long as the mother is pregnant. And that is why we emphasize very much that as soon as the woman has detected that she's pregnant, it's very important for us to start antenatal care. And how does a woman, one of the basic signs for a woman to know that she's pregnant is by missing her periods. If you've been getting your periods every month and that 1 month you're married, you're with your partner, and that 1 month you don't get your period, we need to find out why you haven't got your period. And one of the things that we check for is to ascertain if you're pregnant or not. So as soon as a woman gets pregnant, there are particular complications that can come within what we call the first 12 weeks of pregnancy. There are complications that can come within the second phase of pregnancy, which is between 13 weeks of pregnancy until 28 weeks of pregnancy. And then there are complications still that can come within the third phase, or the latter section of the pregnancy, which we call in our language the third trimester, which is from 29 weeks to 40 weeks. So every pregnancy, it's very, very important that as soon as the mother finds out that she's pregnant, she starts attending antenatal care, and antenatal care should be attended in the hands of skilled birth attendants who are able to interpret that, yes, if I'm in my first 12 weeks and I come in with bleeding, that's a pregnancy that is already becoming complicated. But it's quite an early pregnancy. And if we don't do something about that bleeding, then you may end up losing that pregnancy. If you are within your 12 weeks of pregnancy and you start having a discharge that does not smell well, that is a pregnancy that is already becoming complicated, and we have to find out. There are particular phases at which we are able to establish the growing baby, and if a mother comes in and she's about 8 weeks and we cannot appreciate the baby's heart, then we start, asking a few questions. Where we 8 weeks and not seeing the baby's heart? It also speaks to some of the things that we do when the mother comes and starts attending antenatal care early, because we always do the scan, and majority of the listeners out there would wonder why do we keep asking for these scans. But those are some of the reasons.
I was going to ask you, what are some of the things that are done during antenatal care that could save a mother's life if they had any risk at all?
Yes, a very, very, very good question. And I'll tie that with the previous question, because it's complications at what stage of pregnancy and what can we do to ensure that the mother's life is safe and also the baby's life, because we treat both at the same time. So very importantly, starting to attend antenatal care within the first trimester or as soon as the woman has known that she's pregnant, that's very critical. And the reason is that as a pregnant woman, there are particular changes that your body starts going through. And there are particular tests that we have to undertake to ensure that your body is healthy enough to carry this child, this baby for the 9 months. And some of those we have to check whether you have your blood is safe, you don't have any diseases like HIV, syphilis, hepatitis B. We have to check and ensure that you don't have diabetes. We have to check your blood pressure because there are some mothers that even when they're not pregnant, they already have pressure. And they're on this particular medication, which if we continue with that medication, it will affect the baby. So if, let's say, a mother has any other underlying condition, we have to assess and evaluate what medicines is that mother taking, because there are some medicines that are not safe for the baby. And most especially, and why do we emphasize that the first 12 weeks are very critical? Because that is when the baby is forming, in those first 12 weeks. So it's very, very important for us to ensure that the mother's body is safe. She has no other risks that are endangering her, but also endangering the baby. Then, as we move towards the second phase of the pregnancy, which is 13 weeks to 28 weeks, there we see a few other things starting to develop. More so when the pregnancy reaches, we call it the mid phase, when you clock 20 weeks. The baby starts adding on weight, but also the other support organs of the baby start growing. So there are particular things that we have to really put in consideration. We are in a malaria endemic country, and it's very important for us to ensure that our pregnant women are protected against malaria. And we start that treatment in that phase, the second phase of pregnancy. When a pregnant woman gets malaria, the effect of malaria on a pregnant woman is worse than a non-pregnant lady.
We have seen that we've covered a case here where a pregnant woman did not go early to treat her malaria and the baby came out sick.
Absolutely.
So we covered such a case.
Absolutely.
Some of our viewers must remember that.
Absolutely.
So let's talk about what happens when you delay to go for antenatal care, why it's very important, and also what could result in just going once. Yeah. Yes,
and what would result if you only go once is because we may fail to identify the risks as the pregnancy progresses. Because why do you attend antenatal care is because we're ensuring that you're healthy and safe and the baby is healthy and safe. Within the second phase of pregnancy, we start some vaccines. To ensure that you, the mother, you don't have tetanus. We are also protecting the baby against tetanus, but also there are other conditions that protect the mother and the baby from. So if you miss that opportunity of getting that intervention, then it becomes very hard. Then also we always check for the amount of blood that you have. You have a baby inside you. This baby is growing. This baby is making their own blood. They're making their own fresh, and they're making their own bones. Much of these minerals are coming from the mother. It depends on what you're eating. It depends on how ready your body is to ensure that that baby who's growing right inside you, they are able to draw some of those minerals from you, the mother, to be able to make their own components. So we have to ensure that if your components or some of the minerals within your body are not sufficient enough to cater for you and the baby, then we give you some supplements. And that's why for a number of our pregnant women, we put them on some medicine to boost their blood, because in a pregnant mother, the volume of blood some of the parameters tend to double in order to cater for that demand. So if you don't attend ANC and we fail to identify that, then the chances of you having quite low blood, which will affect the baby. But also the same situation of the case that you discussed on malaria, that baby may not reach 4 weeks. You may end up delivering that baby preterm. But also, during the time of birth, there are mothers that we've encountered, and their blood levels are very low. But remember that whenever you give birth, you're going to lose some bit of blood, which of course is part of this additional volume that you developed during pregnancy. So if we've not prepared your body well for that time, the chances of us losing you, the issue that we are discussing this morning, becomes extremely very high. The other critical issue that we want to try and emphasize is to ensure that within that second phase, we're able to capture any abnormal growths of the baby. And we do that when we do the scans and we evaluate, so that when this mother comes the time of delivering, we're not giving them surprising news that this is the status of the baby that you're delivering. And within the mid-pregnancy, 20 weeks, that's when we see pressure in pregnancy. If a woman has not had pressure in pregnancy, at 20 weeks and their blood pressures shoot up, that's when we are able to catch it early and start that mother on treatment. But also very importantly, if the mother had pressure in the previous pregnancy, there are particular measures that we are supposed to take and put them on some medication. During ANC, mostly around 13 weeks, we start you on some medication to try and reduce on your chances of getting pressure in pregnancy for that second pregnancy that you're carrying. So it's very, very important for us. And also, thirdly, as we continue the conversations around ANC, and we've managed to identify that, okay, this mother is low risk or this mother is high risk, if you come in, because we have different levels that deliver. We deliver mothers from health center 3s to national referral hospitals, but also there are mothers who deliver in some health center 2s. But if you're a high-risk mother and you check in a health center 3, as the ministry, we've established what we call the high-risk pregnancy identification, retention, and response. And that is across all our facilities. So we're able to advise that, yes, ma'am, you've come into this level of care, but based on our capacity, we can't manage your pregnancy. We would advise you to continue seeking antenatal care from this hospital, which would be able to ensure that you're safe and your baby is delivered safe. So pregnancy is a journey.
How many times should I be coming for antenatal care?
8 times. 8 times. And there is a reason why. Previously, 4 times. We had 4 times. But of course, the 4 times that we had challenges. That, as I've said, it's not just about the mother, but it's the mother and the baby. We've realized that as a country, and as you noted in your opening remarks, that we've made significant progress in reducing maternal mortality. In 2016, it was 336 per 100,000 live births. But that number has gone down to 189 per 100,000 live births. But also that 189 is a critical number. We should not have any mother die in this country due to a preventable cause. Now, whereas we've made that stride on maternal health, the newborn side is still a challenge. We are still losing a number of babies. And a number of them end up coming out when they are already dead. So we can hardly explain the circumstances that led to some of those babies dying inside their mother's womb. So the increase on this number of visits is to ensure that we are cutting that number less. But also, there are particular complications. As I've said, you can check into a facility this morning. If you're a pregnant mother, you are 20 weeks, you can go this morning and everything is fine. But then tomorrow, things change.
I was actually going to ask you a question about that. So how is someone supposed to stay safe then? Is there a time where you declare a pregnant mother out of the woods? Say, I think now you should go home, you're fine. Or at this stage, babies are always fine and will survive?
And until the mother delivers, it's a journey that we have to move together.
Okay.
There is never a time, as soon as the woman conceives, until she delivers, that journey between the mother and the healthcare worker, we must work together. You can never say that you are out of the woods until the delivery has happened. But how can we ensure that this mother has an appreciation of what is going on with their body? We try as much as possible, and as the ministry we've developed what we call information leaflets, that a pregnant woman, if you have particular signs and symptoms, that is a red flag. And so you should get to the facility immediately. And some of these, of course, are that you're a pregnant mother and you're bleeding. You're a pregnant mother and the waters, you're having waters flow. You're a pregnant mother and you're having a discharge that does not smell well coming out. Those are danger signs. You have abdominal pain. You have headache, which is persistent, and it's not going away regardless of any painkillers that you're taking. That's a red flag. If you reach 20 weeks, 24 weeks, we expect you to be starting to feel the baby start kicking. One of the things that a mother can know that my baby is alive are the kicks if they have crossed the mid-mark of 20 weeks. Before that, you will not really appreciate those quite well, but beyond that. So we also try to counsel, how do you appreciate you as a mother that your baby is alive? Because we've received situations where a mother keeps home, she has not felt the baby, she's almost term, she has not felt the baby for the past 3 days, and she has kept home comfortable. And by the time she reports the facility, we unfortunately get a baby who's not alive. So at that point, we also advise you that this is the critical indication that the baby is coming out. But also for the first-time mothers, it becomes very important for us to have a conversation with them on when do you get to know that labor has started, because it's your very first time experience. So we have to explain to you what labor looks like. So we advise and counsel the mothers on some of those danger signs, so that as soon as they see anything that is within those signs that I've described, anything away from the normal, then they have to go straight to the health facility.
Where mothers will feel fine, and I say fine in quotes, they feel fine, they feel normal, but when they come to you, they're really in danger? Absolutely.
We've encountered such instances mostly on mothers who present with increased blood pressure in pregnancy. And in most cases, you can't be there. Just like any other normal person, you can't be there, you're doing your normal work, nothing at all. But by the time we assess your blood pressure, it's quite elevated. And it's a later point when you can start getting the symptoms of getting a headache, having your vision quite blurry, and having chest pains and things of the kind. So there can be situations where you're feeling quite fine. But also the other piece is, which is not only for the mother but for the baby, that yes, you can be there, everything is fine, but then you don't have a live baby inside, because you have not yet reached a point where you can easily detect that my baby is kicking, and that's mostly before the 20 weeks. So there are those situations, and that's why we are emphasizing that the contacts of the mother with the frontline healthcare worker should be eight contacts. The 4 were not enabling us to ensure that we are keeping this mother and the baby safe. But for the mothers that have gone through the 8 contacts, we are appreciating that we are getting quite better results for both the mother and the baby.
Yeah, before we break off, let's look at some of the dangerous signs that we should look out for at home. For a mother watching right now that is pregnant, or for a husband watching and has a pregnant wife, what are some of the signs that someone should look out for early to indicate there is something wrong with the pregnancy?
Yes, and I'll just re-echo them, that, and I'll take them in stages, that if the mother is between 0 to 12 weeks, the most common danger sign is bleeding, but you can have water coming out which is not smelling well, or having a fever. those are danger signs within that time. But also, 3, if you get constant abdominal pain, and that abdominal pain can be either in your lower abdomen or could be generalized. And the abdominal pain could come with the bleeding or not. So within the first phase of the pregnancy, those are issues that we need to pay attention to. When it goes to the second phase of the pregnancy, which we said 13 to 28 weeks, to start with, the other 4 within the first are also applicable within that phase. But then there are particular ones that we want to pay attention to, mostly to ensure that a mother is not having hypertension in pregnancy, and that's if you're getting a headache, which is constant and not going away regardless of any medication, if you're having your vision starts becoming a little bit unclear, if you are getting chest pains, and if you have crossed the 20 weeks mark and for some time you started feeling your baby kick, the baby's kicks, but then after that the baby's kicks disappeared, then those are red flags and we need to see you. But also within that time, because the baby starts forming some significant amount of water around them, so that water sometimes, for whatsoever reason, they tend to break. And as soon as that happens, that's also a danger sign. Now, all these, which I've mentioned for the first section of pregnancy, phase of pregnancy, the second phase of pregnancy, are all applicable for the third phase of pregnancy. But also very, very importantly is that once you get pains that you have not been having, and it could be either generalized abdominal pain, all pains that appear as though they are cramps, and you're within the third phase or the second phase or the first phase of pregnancy, plus all these that we've talked about, if at all they occur within the third phase of pregnancy, which is between 28 weeks to 40 weeks, also those are red flags that signify that we need to have a conversation and find out what could be happening.
Okay, briefly talk about some of the other red flags that most pregnant mothers or people around them dismiss as normal that you have come across.
Red flags dismissed as normal, sometimes what we've at times encountered is mostly when it comes to pressure in pregnancy, majorly. Normally, the biggest problem we've got is a pregnant mother getting pain around epigastric pain, pain around, the lower chest here. Yeah. And in most cases, they have mistaken that for ulcers. And the unfortunate thing that we've got that most of those mothers, some of them have ended up in hands of non-skilled birth attendants, and they have managed them for ulcers. And when those mothers present in the hands of the skilled birth attendants and we evaluate, we find that truly the mother was not having ulcers, but instead they were having preeclampsia. So that is one of the commonest signs that people tend to confuse that pain that presents as though you're having ulcers.
When we return from this break, we shall also talk about the cravings. I have seen some mothers eat dirt, eat all sorts of things, so you'll advise us whether that is allowed or not. And so let's take a break, a commercial break. When we return, we shall be talking about maternal mortality. We shall talk more about how to prevent some of these things the doctor has talked about, but also how to seek help immediately once you feel you are in danger. We return shortly. Stay with us. On that break, and thanks so much for staying with us here on NTV Medical Matters. We are supported by Bill and Melinda Gates Foundation. I am Viola Kusasia. You are welcome into the New Year Alpha Show of the Year, and we are so happy to have you once again, just like the way we closed 2025. And today we were talking about mortality rates amongst pregnant mothers, and we have our doctor in studio, that is John Paul Bagala. He is the Assistant Commissioner, Reproductive and Child Health at the Ministry of Health. And before we broke off, we're talking about what are the red flags that you see and take for granted as a pregnant mother or people around you. I just want to remind you that we are streaming live on X and our website, NTV Uganda, but also you can call in and ask your questions directly to the doctor. But for now, doctor, let's focus on cravings during pregnancy. What are some of the cravings that are allowed, and where should we draw the line?
Yeah, the cravings are sometimes, of course, what causes the cravings is the body, still the body. The body gets to demand for something that feels it's really a bit in short supply. And mostly what we've seen is women trying to eat soil or eat clay, or in most cases within Buganda here, the mumbwa.
Yeah.
But mostly what happens in there is it still ties into what we discussed, that when you're a pregnant mother, the baby demands some components for their appropriate growth. And the meals that we have, in most cases around us, may not have enough of those components. So the commonest craving that we have is the soil or the clay, which has one nutrient called iron. And that iron helps the body to build some of its cells that boost the level of blood. So in most cases, if the mother, we've put the mother on sufficient, we've established what their levels of blood are, we've managed to boost to put them on some supplements to reduce on what would cause the craving or to reduce on the shortage, then we are counteracting the craving. That in most cases that goes down. But also what we've observed that sometimes when we prescribe some of this medicine for the mothers, some of them don't take as advised. And so, of course, they will end up, the body will keep demanding. The body will keep demanding. And we try to tackle it scientifically, but also from the traditional sense, dating back in history, there are particular components that our great-great-grandparents used to, before our modern medicines came, they used to utilize to address some of those shortages. Now, majorly that's what we tend to receive, but anything to do with any medicine for a pregnant mother, we advise not to take any medicine without a prescription.
Would you advise them to go ahead and eat whatever their body is asking for? I have seen people go to extremes, you know, like I would not mention that here on air, but yeah, we've seen people do extreme things during pregnancy. So would you advise them to just go ahead and follow their body, especially if they can't have access to the medicine you talk about? Yes,
and what we're saying is the purpose of the constant conversation between the mother and the healthcare worker is to discuss those inner secrets, including my body, I feel like I want to have this. Would you advise me to have it?
Yeah.
So depending on what you're presenting, the healthcare worker is able to analyze that particular component of either medicine or food to evaluate if it has any harmful effect to you, the mother, and the baby. And if we evaluate and it has a harmful effect, then we shall advise whether you should proceed or you shouldn't. So it's a case by case. It's something that we handle case by case. But how do we get to that case by case is through what we discussed in our first segment, that a mother who is not attending antenatal care, you will not be able to establish that conversation with the healthcare worker. For the mother who is frequently attending those visits, as we discussed, they will be able to have those inner conversations with the healthcare worker, and they will be advised on what to do and what not to do.
Apart from the possibility of a baby being dead, how dangerous is lack of fetal movement to the mother?
How dangerous is the lack of fetal movement to the mother? One of the most important signs, as I said, for a live baby is the baby moving. Yeah. But also sometimes if the mother has put on, the baby has grown, but the mother has accumulated significant amount of fluid around the baby, it may be a little hard for them to feel.
We have a caller. I think we have a caller online there. If you can hear us, could you please call again? We shall get back to them.
So what I was saying is that there are particular conditions where the fetal movements reduce and the mother is not able to feel them. What causes these fetal movements? The space within which the baby is able to play. As the baby grows a bit bigger, that space reduces.
Yeah.
So, but also if there are particular conditions, if the mother has accumulated significant amount of, we call it amniotic fluid, around this baby, she may not appreciate those kicks very well. So it becomes very important for us to establish. But also too, if the baby has put on significant weight, the space reduces and they are not able to feel those kicks quite well. So that also is very important for us to advise on how that mother will deliver. But we've received situations where the mother comes, she could be a first, second, or third time mother. She has not delivered, she has not been operated before. And she comes in and at 40 weeks, she's not in labor at all. But we feel we can add her a little bit of time to allow nature take course. That is a time that we also monitor very.
We have someone on the line. Can you hear us? What is your name and what is your question, if you can hear me?
This is Nelson.
Yes, Nelson. What's your question?
My question is what things about gaining weight when you get over?
Could you please repeat that?
What brings about a baby to gain weight when it's in the womb?
Okay, thank you for that. Do we have another caller? We can take multiple before we move on. He says, what causes a baby to gain weight when in the womb? And yeah, I believe causing a hard delivery in the end.
Absolutely.
We should be, I didn't take many calls, but since they're not coming through, we can wait for them.
And I think he called at the time when I was trying to explain the weight, the baby's weight. There is a weight we call the normal weight, that a weight below.
We have another one. What is your name and what's your question?
I'm Andrew from Bali. Just inquiring from the doctor, when does a pregnant mother qualify to get an antidote?
Could you please repeat that and speak up?
When can a pregnant mother qualify to get an antidote?
Which antidote?
Yes, an antidote.
Antidote for what? There are several antidotes.
During pregnancy.
Okay, I'll run through a number of them. Okay.
Thank you for that, Andrew. If we have another person, you can call us and we'll be able to capture all your questions at once before we head back into our conversation. We have someone on the line. Hello, what's your name and what's your question?
This is Sarah calling from Montele. I'd like to ask what causes pre-eclampsia after giving birth?
You captured that?
Yes.
Okay.
And can it heal?
All right, Sarah, thank you. Thank you for your question.
Okay.
Those are three. Captured
Yes.
them?
Yes, absolutely.
That's good. That's good. So I think we can, let's focus on this first, and you can start off with the baby's weight that you
the baby's weight. Yes, and I really want to thank the callers. It means that they are really listening in, and as the ministry, we want to ensure that these conversations are quite more frequent.
Yeah, we have problems in our communities.
Absolutely. And we want to ensure that we are establishing mechanisms to give information to our people. One of the things that before I answer, we are starting to do what we call community health barazas.
There is someone else. Let's get this one more person. We shall answer 4 questions, and that will be that for calls. If you're still there, what's your name and your question, please?
Hello.
Yes, please.
My question is, Hello.
Yes, please, we can hear you. What's your question?
My name is Birunji, and I wanted the doctor to talk more about the malaria part in pregnancy.
Okay, Birunji, thank you.
Okay. So thank you very much indeed for those who have called in, and I'm very happy men have called in, because one of the things that we want to emphasize is also the support of men towards pregnant mothers or their wives. So baby gaining weight. We see significant weight gain in the third phase of pregnancy. That is 28 to 40 weeks. But in most cases, you find mothers who genetically have been delivering big babies. And you ask the mother, have you ever delivered a big baby? And say, oh, if she comes in and she's delivering the fourth, she say, oh, the first one was 4, the second one was 4.5, the other one was 4.3. So we establish that, okay, fine, there is that genetic predisposition for this mother delivering big babies. Yeah. And sometimes, of course, we tend to appreciate, were you able to push those babies, or were you operated? Because then it helps us plan. These big babies sometimes come with some complications during the time of birth. But also, we tend to have mothers mostly who have diabetes. A mother with diabetes, that baby tends to put on significant weight. And if you recall, Viola, we said that the importance of a mother starting ANC early is that one of the things that we screen for is blood sugar. We screen for blood sugar, but also we try to repeat that blood sugar when the mother is almost delivering, because mothers with diabetes tend to have big babies. So we have to take enough history. We have to have a conversation with the mother to establish, is it a genetically predisposed big baby, or is this mother having an underlying condition that is giving us that big baby? Okay. But also, when it comes to weight, there are particular values we look at. And as soon as the mother crosses the 20 weeks, we start evaluating how many weeks are they, what do we estimate? And that's why sometimes when mothers go for ANC, we do those scans to try and estimate what are we estimating in terms of the fetal weight. Because we want to tally, is this baby putting on adequate weight? And also it speaks to the nutrition of the mother, because if the mother is having good nutrition during pregnancy, which we always advise, it goes back to that the baby will take on some nutrients for the mother to develop their body appropriately, and the mother will also have enough nutrients to keep her going. So we look at those parameters, and it goes back to why our pregnant women, supported by the husbands, should be attending ANC, because we evaluate all those. Okay. Now, the other question that came in was on the antidotes. Yeah. Of course, it's quite a very interesting question. But I think one of the things that he has been talking about are the vaccines that we give. One of the vaccines we mostly give is the one against tetanus and diphtheria. And it protects the mother and the baby, so that we are reducing on the mother the number of children who get respiratory tract infections during their early time of life. But also there is another very important antidote, that if we check the mother's blood and we find there is a condition we call when the mother has incompatible blood to the baby they are carrying. We check the father's blood, we check the mother's blood. If you ever encounter, mostly we encounter it with mothers who are negative, all A negative, all B negative, anything negative, and you're pregnant, we cautiously are very keen to know what is the blood type of the father, because it would speak to the potential blood type of the baby. Now, why? The reason is, if this mother is O negative, she's negative, and she carries a baby, delivers that baby, but for some reason the baby's blood crosses into the mother's circulation, the mother's body will be sensitized. The other pregnancies that will follow will hardly survive.
Oh, wow.
So whenever this mother who is negative, O negative, B negative, at 28 weeks, we give you an antidote to try and prevent that sensitization. So we call it the anti-D. So most likely the caller was trying to ask about that antidote. It's a little bit of an expensive drug. So at 28 weeks and 72 hours after delivery, we give you another one. Now, once we've given you that, you are able to deliver your baby, and we've protected the mother's body from fighting the other pregnancies that will follow.
Now, we shall need more time to discuss that. We are running out of our time, but that's something that is very important. You know, I didn't know. I have seen mothers lose babies, yet they have been able to carry a certain baby at a certain point.
Yes.
It would always be a question of, well, how come I can't carry a baby full time, but I had a baby before? So it was always it's a very, very nice point you brought up. You can answer the last question.
Let me answer these other two.
We shall talk about hemorrhage after birth. And so we are running out of time. I can't take another call.
I see we have only 10 minutes.
Yeah,
and so Sarah, preeclampsia after giving birth. So preeclampsia has different categories. That you can have pre-existing hypertension, but as soon as you cross the 20 weeks, you get preeclampsia. Based on our assessment, there are various parameters that we look at. We check your urine, we check your blood, we check your liver, we check your kidneys, and then are able to conclude that yes, you have preeclampsia, but it's occurring on an already existing hypertension. Now, the other one, which Sarah specifically asked, that after delivery, we expect that preeclampsia to resolve.
What is it in simple terms?
Pressure during pregnancy.
Oh, okay.
The pressure during pregnancy. So if it doesn't resolve, there are different. So in some mothers, it can resolve, you know, and we put you on some medicine for about 2 weeks as we monitor you. And that also is the importance of doing what we call postpartum care after birth, because we are able to establish and find out, is your blood pressure after giving birth within the normal ranges? But sometimes we have that small percentage of about 20% of mothers who have had preeclampsia, and it progresses and it fails to resolve. And that mother now becomes a hypertensive person. But it started with preeclampsia. And the importance of postpartum care is that we advise you that now we've taken you through the 42 days. We have to now connect you to another clinician who will support you and care for you with the hypertension, and ensure that before you conceive, you're coming back so that we do what we call preconception care. So in the interest of time, I just want to keep it at that. That there is that situation where even you may not have the preeclampsia during pregnancy, but after delivering, the preeclampsia can come in. And that is the importance that every mother who has delivered to come in the facility within the skilled birth attendant's hands for postnatal care. And finally,
we shall definitely have you back to discuss the same topic. Our viewers still wanted more.
Yes.
We shall have you back.
Malaria in pregnancy. And you have told me, Viola, you hosted someone on malaria in pregnancy here before. But I'm very happy that because malaria in pregnancy is one of the conditions that affects both the mother and the baby terribly. And why? Because a pregnant mother, there is what we call the placenta. All for mothers who have delivered, we call it omwana owokubiri in our lay language. Whenever a pregnant mother gets the small parasites that cause malaria, they concentrate more at that plate, which is the placenta. So the way we manage a pregnant mother with malaria is not the same way we would approach a non-pregnant woman.
Yes, please. We can hear you. What's your question, please, and what's your name?
Hello.
Yes, we can hear you. Please ask your question and tell us your name.
Hello.
I think there is a challenge with the network, but as we can hear you, please ask your question. Could you please step away from your TV set? We cannot hear you well.
I would like to smile.
I think I had time capturing that.
We can't. Unfortunately, we can't hear you.
We really can't.
So sorry about that. But so this malaria, for any pregnant woman, it's important that during that second phase of pregnancy, we start them on what we call Fansida. Of course, the Fansida affects some women. You give them the 3 tablets and they don't take them. But that Fansida is very important because it's what can protect you for about 4 weeks. And that's why some cases women say, because that Fansida can only protect your body from malaria for 4 weeks. And whenever you come after 4 weeks, we have to give you another dose. So protecting a pregnant woman against getting that malaria is more important. Preventing is more important than when we say that we're going to treat. Those are babies that die while still in the mother's womb, babies that fail to put on enough weight. Those are the babies that sometimes come out before the time of birth has reached. So malaria has terrible implications. And also it affects the mother's blood in general. So those are mothers that we lose because the malaria affected her levels of blood. By the time she delivers, her blood levels are very low. And sometimes if we've not captured that quite quickly, or she has not been frequenting, or she just came to the facility at the time of birth, and she loses even the little blood that she had, and she ends up as, we end up losing such a mother. So that's, yes.
I'm just going to ask you one last question, and that question is, what should we know about giving birth itself and after birth, the care that is supposed to be taken? In just 2 minutes, what's the most important thing we need to know? We shall come back with this topic. You can't cover everything at once, so just let us know what we need to know. For example, someone going to deliver like tomorrow.
Yes, Viola.
Yeah.
I know we need to get more time for this, but
we need to.
Very importantly, I think we've touched the risks. Mothers or pregnant mothers should deliver in the hands of skilled birth attendants. They should deliver in facilities. We have a toll-free line as the Ministry of Health where any mother who is having any challenge in any facility, they can call. That is 0800-100-066. We will try to make that a bit smaller. But it's very important because some mothers tend to get difficulties in the facilities where they go. And we want to ensure that we make this quite smooth. Now, you must make sure that the medicine that you're taking during pregnancy has been prescribed. And for the medicine that we've prescribed, take it diligently. Now, the husband support your women and have that conversation. Let's try to establish the discussion as a pregnant woman and the facility where we are seeking antenatal care from, all the healthcare workers that are caring for us. In the private sector, because the numbers are quite small, government, we deliver over 76% of the deliveries we conduct in this country are majorly in public facilities. So we try to ensure that mothers are able to establish that contact with healthcare workers. So antenatal care, delivering in the facilities, and also attending antenatal, postnatal care after delivery.
I didn't know. Is there such a thing?
Of course there is. And it goes back to the question one of the caller asked on pressure during pregnancy after birth, because then we wouldn't. But also the other things that we are able to capture. There are some mothers who tend to bleed after childbirth.
That's what we really needed to
We need to capture that as well. But also the mothers that tend to get what we call sepsis. Sepsis is the 3rd cause of maternal death, mostly for mothers that we've operated. So that postnatal care is very, very important. And we advise that after discharge from the unit, at least within 6 days after delivery, come back to the facility. But we also advise you, we immunize the baby, we check on the baby's growth. For the first time mother, we are able to have a conversation on the breastfeeding and to ensure that you are breastfeeding appropriately, the baby is putting on appropriate weight. But also very importantly, that's when we sometimes, if we've not had an opportunity to discuss family planning within antenatal care, within the postnatal care, we have an opportunity to have that detailed
I think
conversation.
we shall leave our conversation here on postnatal care, which is something that is not very common for a lot of people. Once I've delivered my baby, I run home and go about my life, you know, until all these things show up. So thank you that you've left this conversation here. We shall come back with this topic again, but we appreciate your time this morning and your insightful conversation. So viewers, this is it. We really apologize. We couldn't keep going, but we know you had many questions and all that. We shall come back with this topic, maternal mortality. So make sure you look out for NTV Medical Matters to be able to capture it and also have your questions on the ready for when we return the next time. I am Viola Kusasira. I wish you a very happy new year and enjoy the rest of your day.